there's one thing that's clear to all of us who have worked in gynecology and see patients on a daily basis, is that there is nothing as effective, as consistently as estrogen. There's probably very few things I can use in my practice that's as rewarding as having a woman come in complaining about how miserable she is, and to be able to see how quickly and how significantly the impact estrogen has in her life. Which is probably the reason why it was used in all menopausal women up until about 6 or 7 years ago when the Women's Health Initiative came out, because it really works. Primarily we see that the risks of estrogen come with increases in specific types of other diseases. Number one being breast cancer. And when we measured the Women's Health Initiative in terms of number of women per 10,000, we saw an increased risk of breast cancer that went up about 8 women per 10,000, from 30 to 38. And again, I should remind you that this is using hormone replacement therapy, which is a combination of estrogen and progesterone. I simply state that now because any woman who still has a uterus needs to have both hormones when they're being treated for menopause. If a woman has had a hysterectomy, she only needs estrogen and not progesterone. And I'll get into the difference in a short while. So this is hormone replacement therapy. To us means a combination of estrogen and progesterone. And we saw these increases in breast cancer. In addition, the one that really surprised us was the increases in heart disease. And that increase went from 30 to 37 women per 10,000. And we look at this very cautiously because the Women's Health Initiative put women on estrogen at all ages, at all times. And I think what we have found since the Women's Health Initiative is the likelihood that those women who developed heart disease changes were those women who had not been exposed to estrogen before, had been in menopause for a while, and had estrogen reintroduced into their body through hormone replacement therapy. That seemed to create much more problems than women who were put on estrogen immediately at the time that they went into menopause. And that's an important distinction to make. And those same risks were also seen with stroke and blood clots as well. We saw increases in stroke, which were small, but a pretty significant increase in blood clots, which was about 100% increase, more than a double increase to go from 16 to 34 women per 10,000. And again, those risks seem to be pronounced in women who had been in menopause for a while, were away from estrogen for a while, and had estrogen reintroduced with a prescription. With just estrogen alone, what we really saw, and I did not put those figures in here because, again, I was not trying to get too much into those distinctions, but with just estrogen alone, we did see increases in stroke and blood clots, which were a little smaller than that, and perhaps a very, very slight increase in breast cancer risk, which was still much less than the slide I just showed. Over the last several years since the Women's Health Initiative, our adage that we had to use the lowest dose possible, meaning the lowest dose that took away most of a woman's symptoms, for the shortest time period possible. So when a woman cannot take estrogen, perhaps because of a medical condition, and I think one of the most common ones we see is breast cancer, or when a woman chooses not to take estrogen because of her fear of those risks, the next alternative we can consider is specific types of antidepressants. And again, I'm not giving you these in the order of any preference, except the preference in how well we see these work. Antidepressants work quite well for being able to mitigate hot flashes in menopause. And we use it a lot when estrogen cannot be used. And we see, in addition to the treatment of the hot flashes, we see an improvement in the declining mood that is common as a woman's body is adjusting to the lack of estrogen. The most common type of antidepressants we use are something called selective serotonin reuptake inhibitors. That's a mouthful, but you'll hear us use the acronym SSRIs, and I'm sure you've all heard at least 2 or 3 of these drugs that fall into this category. I've listed them here, Prozac, Paxil, Celexa, Lexapro, and Zoloft. In addition to that, there's a newer one that's added, which is SSNRI. So it uses norepinephrine as a blocking agent too, in addition to the serotonin. The most common example of that is Effexor. These have been used for anywhere from a few months to a few years to help a woman through that transition. And incidentally, I should mention that we also see these types of medications also being very effective for women with PMS for what are probably the same or very similar physiologic reasons. And that is the rapid decline in estrogen and progesterone that occurs in a woman's menstrual cycle is very similar to the one we see as a woman enters menopause. The other types of medications that we can consider using is progesterone, and you'll see that progesterone is used by some camps. The pioneer in that is considered to be John Lee, who's written a couple of books about the use of progesterone, not only for menopausal symptoms, but also for PMS as well. And the theory in the use of progesterone in both of those circumstances is that there is too much estrogen and that the progesterone helps balance that out. And I think from a physiologic standpoint, that seems to make a lot of sense as a woman is going through perimenopause and her estrogen levels are fluctuating up and down. But in menopause, we don't see nearly as tremendous an effect because the estrogen levels have essentially gone away, and there isn't as much progesterone that's needed to balance the estrogen. But we do consider the risks of progesterone use to be fairly similar to what they are with estrogen use. And a lot of that comes from the data I showed before, where the combination of estrogen and progesterone is used. And some of that also comes from separate studies that use progesterone, not necessarily to treat menopausal symptoms, but for other diseases that we use in medicine. That would be primarily increase in blood clots and bloating and all kinds of other side effects that women get just prior to their menstrual cycle. So that we have to consider that progesterone carries probably most of the same side effects and risks as estrogen does. And I think it's important to say that because there's a great deal of marketing that goes on in the use of the natural and bioidentical hormones. And specifically progesterone cream falls into that category, and it seems to be marketed very heavily under that category of natural. And I think it's important to note that those types of medications still carry the same risks as any synthetic type you might receive. The problem is most of the natural types that you purchase are not FDA regulated, where their doses are well controlled or where the other inert ingredients are well documented. So that sometimes we have a little bit more of a problem tracking exactly what you receive or how much you receive when you choose to use the natural. The other types of medications that we can consider are some blood pressure medications. And again, this is to try to counteract the physiologic changes that we know that occur with menopause. And that would be primarily the changes in the blood vessels, the sweat glands, and the heart rate. And clonidine is one of those types of blood pressure medications that we use. In all honesty, we don't use it very often. I think we tend to use it in situations of desperation. But as you can imagine, any other blood pressure medication has with it side effects of fatigue, headache, this particular one, dry mouth, drowsiness, and constipation. So that these can be very difficult for some women to tolerate as well, especially if you have a normal blood pressure or a low blood pressure.